Hello, in this recorded lecture, continuing on with cardiovascular disorders, I'm going to be discussing disorders of blood vessels. And we'll start off our lecture looking at a term called orthostatic or postural hypotension. The term orthostatic hypotension refers to a decrease in systolic blood pressure of at least 20 millimeters mercury or a decrease in diastolic blood pressure of at least 10 millimeters mercury. And this occurs within 3 minutes of moving from a lying down to a standing position. Now, normally, we have these compensatory changes that occur when we go from a lie down to a standing position, where we have this increase in sympathetic activity that's mediated through those stretch receptors or those pressure receptors that we called baroreceptors. And we know those are found in the carotid sinus and aortic arch. Now this reflex response is going to help with the shift in volume that occurs from lying down to standing up by promptly increasing our heart rate, constricting our systemic arteriole, so vasoconstriction. And that helps maintain our blood pressure or keeps us stable in homeostasis. And this occurs very quickly in normal situations, in normal healthy people. Now, these compensatory mechanisms are not effective in maintaining blood pressure within individuals that have orthostatic hypotension. The primary form, there's primary and secondary. The primary form is usually also referred to as neurogenic orthostatic hypotension, and it is usually the result of a neurologic disorder that affects autonomic function. So that is the normal response we want to see of the sympathetic nervous system. Primary orthostatic hypotension is oftentimes chronic, and it's more common in the elderly. So older adults are susceptible to this type of orthostatic hypotension because of slowing of postural reflexes that occur just as part of the aging process. But it can also occur in certain neurologic diseases such as Parkinson's disease. Primary orthostatic hypotension is a significant risk factor for falls and then associated injury from the fall in those that are affected. So a major consideration for management of this condition. Primary orthostatic hypotension is also associated with an increased risk of death, coronary artery disease, heart failure, as well as stroke. Now, this isn't to say that just because sometimes when you get up too quickly and feel a little bit dizzy that you have to worry, because it's not always pathogenic when you experience that. Secondary orthostatic hypotension is oftentimes acute, and it's associated with a variety of different things, including possibly altered body chemistry. It could be related to drug action. For example, if somebody's taking antihypertensives, so that will help reduce their blood pressure. If they are hypertensive, then they are more likely to experience as really a risk or a side effect orthostatic hypotension. Antidepressants are another drug that can cause orthostatic hypotension. Another example would be somebody that has an illness that ends up having to be immobile for a long period of time. Starvation, physical exhaustion, some sort of condition that depletes volume within our body. So remember, volume within our blood vessels is going to contribute to blood pressure. So reduction in volume is going to reduce blood pressure. And any condition that causes venous pooling. So to give you a couple of examples, we have pregnancy is a risk factor for venous pooling, as well as somebody who has varicosities in their lower extremity. That venous pooling could predispose them to orthostatic hypotension because they're retaining more fluid within their veins that should normally be returned to the heart, which would be contributing then, when it's put out into the systemic circulation, contributing to an increase in volume in our systemic circulation or in our arteries, and therefore also increasing pressure. In other cases, it can be chronic, but most often acute. In other cases, it can be chronic, and that can be associated with adrenal insufficiency. So remember the adrenal glands that sit on top of our kidneys that release catecholamines and other substances. It can be related to diabetes, cardiovascular disease, as well as paraneoplastic syndrome. Paraneoplastic syndrome, neoplastic, we're talking about some sort of growth, which in this example is usually cancer, so a cancerous tumor or neoplasm. Paraneoplastic syndrome is a group of rare disorders that are triggered by this abnormal immune response to a cancerous tumor. So someone has a cancerous tumor and their immune system responds abnormally to it and can cause a variety of different disorders. Signs and symptoms that are common in those with orthostatic hypotension, they'll report being dizzy, they may have blurring or loss of their vision, and fainting, which is syncope. Next up, we're going to be looking at two different conditions, Raynaud's phenomenon and Raynaud's disease. And so we'll look at them individually in a moment, but what I want to mention first is that the clinical manifestations of both the phenomenon and the disease are very similar, if not considered the same, but the causes do differ. Raynaud's phenomenon and disease are characterized by these attacks of vasospasm in the small arteries and arterioles, particularly in the fingers, but it could occur in the toes. Common clinical manifestations include paleness, which you can see very clearly here. If there is sluggish blood flow, it can end up causing blueness, so cyanosis. Some people report numbness, a cold sensation, and pain. Now, that's usually during the vasospasm, but after the vasospasm, as blood flow is returning, there can be redness, which is rubor, pain, and paresthesia, or numbness and tingling. We're going to look at each of these. The disease form is called primary Raynaud. And with this, the vasospasming that's occurring is of unknown origin. But what is known is that there is some sort of imbalance between vasodilators and vasoconstrictors. And so obviously there is an increase overwhelmingly with the vasoconstrictors, hence the reduction in blood flow to the digits. And these substances come from the endothelial tissue within the blood vessel. It's more common in females if you have a family history of it. More common if you smoke, if you have a manual occupation where you're using your hands a lot, if you suffer from migraines and cardiovascular disease. And so what will bring it on? Well, the person will have either brief exposure to cold, whether it's outside or they put their hands in a freezer or they're holding on to something cold, or emotional stress can also bring it on. Secondary Raynaud's or Raynaud's phenomenon is secondary to some systemic disease. So somebody has a disease or condition and then they suffer from Raynaud's phenomenon because of it. For example, collagen vascular disease can cause Raynaud's phenomenon, and an example of one is scleroderma. Scleroderma is an autoimmune connective tissue disease that causes inflammation of areas within the body, including affecting the vessels. Chemotherapy, cocaine use, hypothyroidism, so a low-acting thyroid, pulmonary hypertension, as well as other conditions. We're going to move on to talking about disorders of veins, but first we'll have a quick look at the normal structure and function of veins. Veins, compared to arteries, possess these valves that are going to encourage one-way direction of blood towards the heart, because we know that veins are designed to be taking fluid from the tissues and returning it to the heart. Most of our blood is actually in our systemic veins and venules. It's sort of like a reservoir, but we still need to be able to return it to the heart. So the one-way valves that are seen here should, in theory, close behind as blood moves through so that it moves in one direction. But in cases where we have either age or some other condition that affects the valves, they don't work properly and blood can backflow. Pressure in veins is significantly lower than in arteries, and that is demonstrated here where you can see that drop in pressure as we get into venules and then increase in size in our veins, very low pressure. So how does blood get back to the heart, especially from the extremities? Well, we rely on our skeletal muscles to do a lot of that. And this is showing you veins despite the red color. And when our skeletal muscles contract, let's say in our calf, so the lower part of the leg, they will compress the vein, increasing pressure, encouraging it to move in an upward direction. And then the other method by which we return venous blood to our heart is by breathing. Breathing is going to create pressure changes that allow blood to move from areas where it's under higher pressure to lower pressure towards the heart. Let's talk about varicose veins. Varicose veins are swollen, twisted veins that lie just under the skin and oftentimes occur somewhere within the legs. And there are a variety of different causes, and some people are just predisposed to varicose veins. But some examples include people that are standing still for extended periods of time. Maybe their muscles are not contracting enough to encourage blood to move back, so it pools in the lower extremities, and eventually the vein walls can't hold that volume of blood, so they enlarge. People that cross their legs a lot at the knee, this can prevent that calf muscle pump or leg muscle pump from working properly. Even wearing constricted clothing can reduce the proper movement of blood, especially from our lower extremities upward. But in any case, blood pools in the veins can't handle that volume, and then the walls become weaker and they dilate. And then this can cause veins to not work properly as well because of all these pressure changes, and blood can backflow. Blood will continue to accumulate in distended veins and just kind of stay there. And the problem with this, aside from it being uncomfortable and visually unappealing, it can increase the risk of clot formation. As we know, anytime we have stationary blood, clots can form. It also increases hydrostatic pressure within veins. So hydrostatic pressure is a pressure exerted from a fluid against a wall. So this would be the fluid of the excess blood in the veins against the vessel wall can cause it to leak out of the vessel and into the tissue, leading to peripheral edema. Veins can appear very distended and tortuous. They can be palpable in some cases if they're superficial and large enough, and not just palpable, but also noticeable. Varicose veins are very common, and they won't always lead to something that's more concerning, but in some cases, it can lead to what's called chronic venous insufficiency, where over a long period of time, we have this inadequate venous return to the heart. And it can be due to varicose veins, or somebody could have valves that just are not functioning properly, allowing for that normal return to the heart. But in any case, it can lead to, in more serious cases, venous stasis ulcers and deep vein thrombosis. When people have varicose veins, especially once they've progressed, it really is a form of venous hypertension. There's excessive volume in the veins in this area, which is going to lead to an increase in blood pressure. We have this state where the blood is not moving properly, it's sitting in the area. The tissues can start to end up not getting the normal blood supply that they need because of this difference in pressure now between what's in the veins versus in the arteries. And this can lead to a lot of swelling and pain. It can even lead to changes in the person's skin. But in more serious cases, it can lead to necrosis that can lead to which is what's called venous stasis ulcers. And these can get infected and things can progress to the point of amputation. And so why do these ulcers form? Well, because blood flow in the area is obstructed. The arterial blood cannot push past this obstruction caused by the dilated veins. And then deep vein thrombosis, we will talk about on the next slide as our second last topic. It's not uncommon for thrombi to form in veins because the blood is more likely to pool and form a clot. A deep vein thrombosis is a blood clot that remains attached to a vessel wall, usually within the lower legs, oftentimes in a single leg, so just one. There are 3 factors called the triad of Virchow that promote venous thrombosis, or the formation of a clot within a vein. One is venous stasis, so blood is not in the veins is not moving properly, and it could be for a number of different reasons, including what we spoke about earlier, varicose veins. Venous endothelial damage, so there's damage to the inner part of the vessel for whatever reason. And a hypercoagulable state, so this is where the person is more likely to form a clot. So they might have an inherited disorder that makes them more likely, or maybe they're taking oral contraceptives, which predispose you to clot formation. Pregnancy also predisposes you to clot formation. These are just some examples. Now, the problem with deep vein thrombosis is that the symptoms are oftentimes not there early enough to detect that there's a problem. But in other cases, if you look at the person's, let's say, calf, for example, which is the area that's more likely to form a deep vein thrombosis, is that it'll be red. There might be some pain. You can notice some swelling when you compare it to the other leg. There could be vein discoloration or just discoloration of the leg in general. There's also an orthopedic test called Homan's sign, which I'll just describe to you briefly, where the person's ankle is forcefully put into dorsiflexion. And if there is a deep vein thrombosis, that action pulls on the vein enough that the person will have pain if there is a clot in that area. But there are states where you might know that somebody is going to be at risk of developing a deep vein thrombosis. And so this is where prevention is going to be especially important. So maybe after somebody's been immobilized because of an injury or surgery, where they might need to be given prophylactic, so preventative anticoagulation medication to reduce the odds that they will develop a clot. I had a patient myself a few years ago that came into my clinic because she'd hurt her calf muscle, or so she had thought. And when I assessed her calf, I did notice that there wasn't anything obviously different between the two. She had a mildly positive Homan's sign. She's a smoker, she's overweight, and she's on birth control medication. And so those are all risk factors. And she's not very mobile either. So all things that promote stasis of venous blood. So I had told her that I suspected a deep vein thrombosis. She refused to go to the hospital despite my recommendations. And so I said to her, if at any point in time you experience pain or changes in the color of your skin, or if you have shortness of breath, you need to get yourself to emergency immediately, because she could have had that clot dislodge from her lower extremity, travel through her venous system, thinking about the normal pathway of blood throughout the body, to the right side of the heart, to the lungs, where it gets lodged and causes a pulmonary embolism. And sure enough, in her case, about 2 weeks later, she went out for a quick walk with her dog and had shortness of breath. And she said in the past she's had shortness of breath, but it concerned her because I had mentioned it. So she called 911, and sure enough, she was having a pulmonary embolism. So complications of a DVT, I already talked about that, where you have that thrombus that breaks off, which we know is then called a thromboembolism, or an embolism because it's a traveling clot, gets lodged in a pulmonary vessel, leads to ischemia and then infarction, and then can lead to all of the different things that we've talked about with heart failure. Now, pulmonary embolism won't always cause an infarction, but it's absolutely necessary to get it looked at immediately and treat it and get that clot dissolved so that there isn't lung damage. On our final topic, we'll talk about superior vena cava syndrome. This is a clinical manifestation of progressive compression of the superior vena cava. And so it leads to distension of the veins in that area. So remember, the superior vena cava is the superior vein that would normally bring blood or return venous blood to the heart into that right atria. But if it becomes progressively compressed over time, it's going to reduce the amount of blood that can return to the heart from the head and the upper extremities. So it's going to back up and cause dilation of those affected veins. The leading cause of superior vena cava syndrome is lung cancer and lymphoma, but there are non-malignant causes such as cystic fibrosis. It can also be caused by other things as well, clots, infection, but we're not getting into detail on that. Clinical manifestations will include swelling anywhere distal to the superior vena cava. So if you follow along the vessels where blood backs up, it's going to cause distension of those veins because we have an increase in volume that shouldn't be there. So it can lead to swelling in the face, the arms, and the chest, and jugular venous distension, which we've talked about already. Normally, the superior vena cava it's this thin-walled and relatively low-pressure vessel that lies really within a closed thoracic compartment. And so any tissue expansion, especially in the lungs, if somebody has lung cancer at the top of the lungs here, where we can see a tumor here, it's not going to take much to compress that superior vena cava. Plus, the superior vena cava is surrounded by quite a lot of lymph nodes and lymph chains. So if those become inflamed, as they can be with certain cancers or even an infection, that can also compress the superior vena cava. Okay, that's the end of this lecture. I hope you enjoyed it. Thanks for your time. Bye for now.